Welcome back to this next video in which we are discussing coronary artery disease. Okay, so what we're going to move on to in this next video is discussing the treatment for both angina and also acute coronary syndromes. Okay, so we're going to discuss not just drug treatment, but also more invasive treatments and also lifestyle changes that can help to improve your prognosis. Okay, so we'll begin with the treatment then for stable angina pectoris, and remember this is where you have some atherosclerotic plaque in one of your coronary arteries, and this isn't a problem at rest because the portion of the coronary artery that has the atherosclerotic plaque in, it will permanently be vasodilated to its maximum ability to try and keep blood flow through it at rest at a normal level. Again, this will mean that the myocardium downstream of that coronary artery will usually be receiving an adequate amount of blood at rest. It only then becomes a problem when you try and exercise, because of course when you try and exercise your cardiac output needs to go up, and this requires the heart to be working harder, and if the cardiomyocytes are going to be working harder, they're going to need a greater blood supply. So what usually happens in a healthy individual is that all the coronary arteries dilate so that you get an increased amount of blood flow to the myocardium. Okay, however, this isn't going to be able to occur within this coronary artery that is already maximally vasodilated. So you're going to therefore get ischemia to the portion of myocardium downstream of that coronary artery during exercise, and that's going to cause lactic acidosis in that portion of myocardium, and that will cause a crushing chest pain known as angina pectoris, which will happen every time you exert yourself. Okay, right, so treatment then for angina. We can divide the treatment into three main categories. Okay, treatment that is designed to reduce the progression of atherosclerosis. So treatment that's designed to make sure that the atherosclerotic plaque doesn't get any bigger, that you don't get more atherosclerotic plaques in other coronary arteries or indeed in other blood vessels all around the body. So anti-atherosclerotic treatment is one of the one of the categories of treatments that we're going to be looking at. Secondly, we can have the actual anti-anginal treatments, which are treatments that aim to allow you to do more exercise without actually suffering an angina attack. So trying to prevent the angina from actually occurring when you exercise. And thirdly, drugs that are actually going to try and prevent you suffering a heart attack. So drugs that are going to stop thrombosis from occurring if the atherosclerotic plaque does rupture. Okay, so those are the three separate categories of drugs that we're going to go through. We're also then going to look at more invasive treatments such as percutaneous coronary intervention and also coronary artery bypass grafting. So that's an outline of the treatments that we're going to look at then for angina pectoris. So we'll start off with the anti-atherosclerotic treatments. Okay, so these are treatments that aim to reduce the progression of atherosclerosis, so to try and stop the atherosclerotic plaque that you've got from getting any bigger, and to try and stop you getting any more atherosclerotic plaques, which might lead to coronary artery disease in other coronary arteries. So anti-atherosclerotic treatment then. Okay, right. So firstly, there's a lot of things that don't actually involve drugs that we can do to try and reduce your risk of developing further atherosclerotic plaques or developing the atherosclerotic plaques that you've already got. Okay, so we're going to try and give you advice on lifestyle changes to reduce the risk factors then for the development of atherosclerosis. So if we remember back to the way in which atherosclerosis develops, remember it's caused by chronic injury to endothelial cells in the region where the atherosclerotic plaque is going to develop. So we can try and remove whatever it is that is causing chronic injury to those endothelial cells. So for instance, if you smoke, then it could be the toxins that you're breathing in when you smoke which are going into your bloodstream and which are then damaging the endothelial cells chronically. Okay, so we can advise people to try and give up smoking. So smoking cessation is a big part of anti-atherosclerotic treatment. Okay, in addition, let's think of other risk factors that are there for the development of atherosclerosis which can injure endothelial cells. So if you have poorly controlled diabetes mellitus, that was another big risk factor for the development of atherosclerosis, because remember, if you have poorly controlled diabetes mellitus, you're going to have resting or fasting hyperglycemia. And too high blood glucose continuously in your bloodstream, that can damage endothelial cells for reasons that are still not particularly clear, but it can. So what we will do in these people with coronary artery disease is we will test their blood glucose. We'll do a test and see what their blood glucose actually is, and try and see if they have potentially undiagnosed diabetes mellitus, and if they do, of course, we'll give them treatment to try and get that under control. Okay, so we'll be looking for undiagnosed diabetes mellitus, or if they do have diabetes mellitus, we'll be looking at how well they're actually controlling it, and if they're not controlling it that well, then we'll take steps to try and ensure that they control it better. Okay, so dealing with diabetes mellitus is another big thing that we can do to try and prevent further atherosclerosis from occurring. In addition, another big risk factor for atherosclerosis is if you are hypertensive. So we can also have antihypertensive treatment. So remember, if your blood pressure is too high, then this can be damaging the endothelial cells, because of course that's going to be pushing on the endothelial cells continuously. So you can imagine that that can lead to endothelial cell damage over time as well. Okay, so if you've got hypertension, then we'll also be looking at putting you on antihypertensive therapy, and indeed quite a few of the drugs that are used in antihypertensive therapy are also used to actually treat the symptoms of angina. So there's going to be some nice overlap here, where the anti-anginal drugs that I'll come on to in a moment are actually going to reduce your blood pressure anyway, so they're also going to reduce the risk factor for atherosclerosis development. And indeed, quite a few of the people who do develop coronary artery disease are hypertensive. Okay, right. In addition, of course, the other major risk factor for atherosclerosis is your LDL level in your blood. Now remember, the LDL level doesn't really damage the endothelial cells, but it's a crucial part in the pathogenesis of atherosclerosis. So once the endothelial cells have been damaged, remember, we're bringing in LDL into the subendothelial space. The higher your LDL concentration in your blood, and remember, LDL is just these particles carrying cholesterol in your blood, the higher your LDL level in your blood is, then the more LDL you're going to get coming into the subendothelial space, the more rapidly you're going to develop a larger lipid core to the atherosclerotic plaques. So LDL accelerates the progression of atherosclerosis. Although it's not the original cause, having an elevated LDL accelerates the rate at which the atherosclerosis will occur. So it's a major risk factor for the development of large, unstable atherosclerotic plaques. So we're also going to try to lower your LDL level. And LDL, low density lipoprotein, it's just these storage particles for cholesterol. So when we say lower LDL, you could also say lower blood cholesterol. Okay, so how can you lower blood cholesterol? Well, one of the ways, of course, is to try and limit your dietary consumption of cholesterol, so another lifestyle change here. Okay, so we'll be looking at diet and trying to reduce dietary cholesterol. And cholesterol is found in fatty foods. Okay, it's very lipid soluble, so it's often in foods that contain lots of other sorts of lipids as well. So butter and other dairy products and things like that are going to contain large amounts of cholesterol. So we try and limit the amount of those that you consume. And obviously, if you're consuming less cholesterol, then you're going to end up with less cholesterol in your blood, you'll end up with fewer LDL particles. In addition, alongside dietary changes, we can also put you on statins. Very important drugs, very heavily prescribed drugs, and very safe drugs overall. So let me give you 4 major examples then of statins, and then I'll discuss how these are actually going to work, and I'll give you just the basic explanation as to how they work. Okay, so I'll give you 4 major examples. So the 4 major examples of statins are rosuvastatin, atorvastatin, simvastatin, and pravastatin. So I'll write them all down. Atorvastatin is the second one. Then we've got simvastatin. And then finally at the bottom, pravastatin. And this list that I've given you here, this is in order of the potency of them. So rosuvastatin is the most potent, it's the most effective, very strong statin. And then down to the bottom where we've got pravastatin, which is the least potent, the least strong. Okay, so this is a list in order of potency, and these are the major ones that are prescribed: rosuvastatin, atorvastatin, simvastatin, and pravastatin. And for instance, if we start you off on pravastatin and it's not having that much effect, we can move up, for instance, to a stronger one such as rosuvastatin. Okay, right, so nicely they all end in the suffix statin, and how do these drugs actually work to lower LDL level? Well, they work by inhibiting hepatocytes in the liver from synthesizing cholesterol de novo. So let me just explain this. So if I draw a little picture of the liver here, the liver needs cholesterol. Okay, the liver cells, the cells in the liver, and I'll just draw a cell of the liver, completely out of scale here, so this is supposed to be representing the entire liver, and here, zoomed in on hugely, this is supposed to represent a cell of the liver, so this is a hepatocyte. Okay, so the cells of the liver, the hepatocytes, they need cholesterol. Okay, cholesterol is a very important molecule to them, and they use it to synthesize bile salts. Okay, so hepatocytes are always using cholesterol to synthesize bile salts, which are an important component of bile, very important for emulsifying fats in the gastrointestinal tract so that they can be digested and absorbed. So the hepatocytes are continuously using cholesterol to make bile acids or bile salts, whatever you want to call them. Okay, right. So hepatocytes need a supply of cholesterol, and there are 2 ways that hepatocytes can get the cholesterol that they need in order to synthesize bile acids or bile salts. And the 2 ways that they can get it are either they can take it from the blood, so they can take it from LDL particles which are circulating in the blood and storing cholesterol in the blood, or they can actually synthesize it from acetyl coenzyme A, which of course is a molecule absolutely central to the metabolic processes inside cells. Okay, it's the product of the link reaction which occurs after glycolysis. So in the normal respiratory reaction where you take glucose and catabolize it down, you firstly have glycolysis and then the link reaction, and acetyl coenzyme A is the product of that, and then that goes into the Krebs cycle. Okay, so it's a molecule that cells have a lot of and is central to metabolic processes. Okay, and this synthesis pathway is often called de novo synthesis. So de novo means from the beginning. So this is synthesis from very elementary molecules. So hepatocytes are actually capable then of synthesizing cholesterol with a de novo synthesis pathway. Okay, and this pathway is incredibly complicated. You know, if you go to a biochemistry textbook, you can look it up. It takes a huge number of steps to actually synthesize cholesterol from acetyl coenzyme A, but hepatocytes can do this. Okay, so when they need some cholesterol, they can either get it from the blood or they can synthesize it de novo. The way then that statins work to bring LDL level down in the blood is they inhibit this pathway. They inhibit one of the enzymes in this pathway, the famous enzyme HMG-CoA reductase. Okay, so I'll just write its name down here. So there is an enzyme involved in catalyzing a very important step in this de novo synthesis pathway known as HMG-CoA reductase. And these statin drugs here, rosuvastatin, atorvastatin, simvastatin, pravastatin, they all work by inhibiting this enzyme, and therefore they inhibit the entire de novo synthesis pathway. Therefore, a lot of this is going to be abolished, and the hepatocytes, they still need the cholesterol for making the bile acids, so they're going to take more cholesterol from the blood, and therefore LDL level in the blood is going to go down. So that's the way that statins work to reduce LDL level within the blood, to reduce blood cholesterol. But they should be taken in accompany to dietary changes to try and bring about the desired drop in blood LDL level. Okay, so there's the anti-atherosclerotic treatment. So to try and prevent the atherosclerotic plaque that's already in your coronary artery from getting any bigger, and also to try and prevent you getting any more atherosclerotic plaques either in the same artery or in other coronary arteries, or indeed in other arteries in the body, because having atherosclerotic plaques in other arteries of the body can lead to peripheral vascular disease, can lead to many different complications depending of course on which artery we're talking about and which organ it supplies. Okay, so anti-atherosclerotic treatment is a major thing that we put people who are suffering from coronary artery disease on. Okay, now let's actually talk about the anti-anginal drugs. So these are drugs that are specifically trying to reduce angina, and angina refers to the crushing chest pain that you get when you exercise in stable angina. So anti-anginal drugs, and these are not painkillers. Okay, so the way we do this is not that we just give you a painkiller. Anti-anginal drugs are going to actually try and prevent the ischemia from occurring in the heart, and the way they're going to do it is they're going to work by trying to reduce the amount of work that the heart is actually doing, to try and reduce the heart's oxygen demand. And of course, if we reduce the heart's oxygen demand, then we reduce the amount of anaerobic respiration that's occurring in the cardiomyocytes. Therefore, we reduce the amount of lactic acid that we're producing, and therefore we're going to reduce that stimulus for the pain. So they are not just painkillers, they are drugs that are going to try and prevent the cause of the pain rather than actually just target the pain itself. Okay, right. So a lot of these drugs are going to work actually by lowering blood pressure, as we'll see. So the first anti-anginal drug then that I want to talk about is a nitrovasodilator by the name of glycerol trinitrate, and this one is given to people to take when they're actually having an angina attack. So this is given for relief from an angina attack. So if you are suffering from stable angina and you do go out and do some exercise, you have to run to catch a bus maybe, and then you're suffering from an angina attack after that, then this is a drug that you could take and it will act very quickly to give relief to the angina attack. It will get rid of the angina. Okay, right, so this is in a class of drugs known as nitrovasodilators, and I'm going to talk about another nitrovasodilator in a moment, which will be given prophylactically rather than as required. But we'll start off with this one that's given as required. So nitrovasodilators, and I will explain why they're called nitrovasodilators. So the first one that we're going to discuss then is called glycerol trinitrate, and you'll often hear it abbreviated to GTN. Okay, so if anyone's talking about GTN, you now know what it means, glycerol trinitrate. Okay, so as I say, glycerol trinitrate is given as required, and the fancy terminology that is used in medicine for take as required is the symbols PRN. Now, I think this comes from Latin and stands for something like pro rata, but the gist of what this means is take as required. Okay, so whenever you see on a drug chart or anywhere in medicine the symbol is PRN, this means, it's written in Latin, but it means that you should take the drug when it's required. Okay, so glycerol trinitrate is a PRN drug. It's taken as required. Okay, and the way that it's administered is sublingually, so another abbreviation here, S/L means sublingually. Okay, so you put it underneath your tongue, and there's two different ways that you can actually administer it. You can either have it as a spray, and you'll give yourself a couple of sprays underneath your tongue, and the drug will be absorbed into the blood vessels underneath the tongue, or you can actually have a tablet which you put underneath the tongue and which will dissolve, and then the drug will be absorbed into the blood vessels underneath the tongue. So it's sublingual delivery rather than oral delivery. And the reason you can't give it orally is because there is a substantial first pass effect for glycerol trinitrate. So what does the first pass effect mean? Well, the first pass effect is all about when you take drugs orally. Okay, if you take a drug orally, the drug will be absorbed into the blood around the gastrointestinal tract, and it will go, of course, into the portal circulation. So it doesn't go straight back into the systemic circulation. Before that, it has to go through the liver. And when we talk about drugs having a bad first pass effect, we mean that if they were given orally and they go into the portal circulation, they're all taken out by the liver before they ever arrive in the systemic circulation. Okay, so the first pass effect is the concept that the blood concentration of the drug in the portal circulation can be much higher than the amount of drug that actually gets into the systemic circulation, because of the fact that the liver is taking loads of the drug out when the blood first goes through the liver. So it's called the first pass effect because the blood has to first pass through the liver, and it's there being taken out before it ever gets into the systemic circulation. So glycerol trinitrate, it is absorbed from the gastrointestinal tract, but it's all obliterated by the first pass effect. The liver is going to take it all out and destroy it. So you're not actually going to see any of the glycerol trinitrate arriving in the systemic circulation. So that's why you can't give it orally, and instead you have to give it sublingually, because of course then you bypass the liver and it just goes straight into the systemic circulation. Okay, so this will work within minutes then, and it will produce relief from angina. So if you're suffering from an angina attack and you deliver a little bit of glycerol trinitrate into your systemic circulation sublingually, it will provide you with relief from that angina attack. It will make it go away, okay, within a few minutes. Now, how does glycerol trinitrate work, and indeed how do all the nitrovasodilators work? And we will see another example in a moment. So the nitrovasodilators, the way they work is they go into the systemic circulation and they are everywhere in the bloodstream. So you've got drug everywhere. Okay, and what then happens is the drug is broken down to release nitric oxide. Okay, so this is what all nitrovasodilators do. They break down, they undergo a chemical reaction to release nitric oxide, and they're going to be doing this all over the place in the bloodstream. Okay, and this nitric oxide is going to do exactly the same thing that it would do if it had been produced by endothelial cells. It's going to diffuse into the vascular smooth muscle cells around blood vessels all over the body, and it's going to cause relaxation of those vascular smooth muscle cells, and we discussed the pathway earlier on for how nitric oxide actually produces relaxation of vascular smooth muscle cells. I'll just see if I've got the picture over here, and I do have it. Here is the pathway. Here, nitric oxide goes into the vascular smooth muscle cell, activates the soluble guanidate cyclase, which is then going to start breaking down guanosine triphosphate, GTP, into pyrophosphate and cyclic GMP. The cyclic GMP is then going to activate protein kinase G, and protein kinase G will phosphorylate and inactivate the myosin light chain kinase. And remember, myosin light chain kinase, to keep this simple, it's the on-off switch. The level of activity in myosin light chain kinase determines how contracted the smooth muscle cell is. Okay, so it controls the activation of the contractile machinery, the actin and myosin filaments in the vascular smooth muscle cell, and therefore its level of activation reflects the level of contraction of the vascular smooth muscle cell. Okay, so if we've inactivated lots of myosin light chain kinase enzymes, that's going to result that's going to result in a more relaxed state for our vascular smooth muscle cell. Okay, so we're going to get vasodilatation all over the body. Now, why is that actually going to be beneficial in angina? Well, people's instant thoughts on this is brilliant. That will cause vasodilatation in this coronary artery that isn't conducting enough blood to this ischemic portion of myocardium, so we'll increase the blood supply to that portion of myocardium. Bingo, there is the solution to the ischemia there, and that's why you'll get relief of angina. But remember, that's not what's going to happen, because at the point where you've got the atherosclerotic plaque, the artery was already maximally vasodilated in the resting state. That was the problem. Remember that the beta-2 adrenoreceptors activated by the sympathetic nervous system when you commence exercise on the vascular smooth muscle cells aren't actually going to be able to produce any further relaxation, so you can't open that blood vessel anymore. That was the reason that it only arose as a problem when you exercised, that you couldn't vasodilate that artery anymore. So that can't be how these nitrovasodilators are going to produce relief from angina, and in fact we now think that the reason that they produce relief from angina is that this vasodilatation is going to be occurring all over the body. Okay, so in all the arteries and the arterioles you're going to get vasodilatation. In all of the veins you're going to also get vasodilatation. Now that's going to reduce two incredibly important parameters. It's going to produce mean arterial blood pressure. Okay, it's going to reduce mean arterial blood pressure, often abbreviated down to BP. So when you see BP, that means mean arterial blood pressure. It's also going to reduce central venous pressure, the pressure in the venous system, and that's very, very important. Don't just think that it's this one that's going down. It's also the fact that the pressure in the venous system is going down. So if all of the veins start dilating somewhat, then the pressure in the venous system is going to go down as well. And central venous pressure, CVP, means the pressure, in the superior vena cava, in the inferior vena cava, those massive great veins. Okay? So not only is mean arterial blood pressure going to go down, but also central venous pressure is going to go down. Now, this is going to mean that the heart doesn't have to work as hard. Okay, this is the way it's going to work to relieve the angina. Remember, the ischemia is only a relative ischemia. It's not, remember, the word ischemia doesn't mean that you have no blood supply to that area of myocardium. You do have a blood supply to the area of myocardium. It's just that the blood supply isn't adequate to meet the demand of that myocardium. So if we want to get rid of the ischemia, one tactic will be to increase blood flow. We've said that's not going to happen. The other tactic would be to make the demand of that myocardium reduce, okay, to reduce its actual demand for oxygen. And how do we reduce its demand for oxygen? We reduce its ATP consumption. So we make it work less hard. So how can we make the myocardium work less hard? Well, by reducing these two things. Because if you reduce central venous pressure, that means that the amount of blood that is going to be pushed into the heart during relaxation, during diastole of the heart, is going to be reduced. Okay, so if you imagine the refilling of the heart, what determines how much blood is actually pushed into the heart? Well, of course, it's how high the pressure is in the venous system. We've reduced the pressure in the venous system, therefore the amount of blood that the heart is going to fill with in diastole is going to be reduced. Okay? Now, if the amount of blood is reduced in the heart before systole, then that's going to reduce the amount of work that the heart does, because remember that important law that you will have learned in physiology years and years ago maybe, the Frank-Starling law of the heart. So this is what it all comes down to, the Frank-Starling law of the heart. Now the Frank-Starling law of the heart is very, very simple. It says that if you push more blood into the heart, if you fill the heart to a greater capacity, if you stretch the walls of the heart by pushing more blood in during the diastole period, then the heart will contract harder so that it can expel as much of that blood as possible. Okay, so the amount of force that the myocardium generates is proportional to the amount of blood that you have forced into it during diastole. Okay, so if we're now going to be forcing less blood into the heart during diastole, then of course the cardiomyocytes are not going to contract as hard because of the Frank-Starling law, because they're contracting on a smaller volume of blood. And remember, the reason for the Frank-Starling law is believed to be that if you stretch the wall of the myocardium out by pushing a huge amount of blood in, then you stretch out loads of the sarcomeres that wouldn't have been stretched out before, and they now get into positions where they would be able to contract now. Okay, so you get more sarcomeres contracting and therefore more force generated, but also the problem is that if more sarcomeres are contracting, more ATP is going to actually be used. And I think I'll just draw a little picture to explain this. So, if you fill the heart with more blood, then you stretch the wall of the myocardium more. So, before the heart is contracted, the cardiomyocytes now will be more stretched out, and this will mean that the sarcomeres will be more stretched out. So, some of the sarcomeres in the cardiomyocyte previously might have already been down in a state where they're not actually going to be able to do any contraction because the myosin filaments are already completely up to the Z discs. Okay, and that picture's awful, it's too small, so I'll just draw a bigger sarcomere here. So if you imagine having a sarcomere that's in this sort of position, like so. So here's a Z disc, here's a Z disc, here are the actin filaments, and let's say the myosin filaments are like this. So the sarcomere is already in a state where it can't really contract any further. Now note, this is not an active sarcomere. The myosin filaments might not be interacting with the actin filaments here. It's just that it's in this state where it's already in a contracted length. It's not actually contracting at the moment, but it's just permanently in this contracted state. Now, with the myosin filaments, completely overlapping with the actin filaments in this way, and the Z discs very close together. Now, if you would then stretch the cardiomyocyte out, of course, this sarcomere might now be stretched out into a position where if you activated the interaction between the myosin filaments and the actin filaments by allowing calcium into the cytoplasm, then it would actually be able to contract back down and generate some force from that, and of course also consume some ATP. Okay, so that's the theory of why the Frank-Starling law of the heart actually occurs, that in a cardiomyocyte, at its normal sort of length, you don't have all of the sarcomeres stretched out and in a position where if there is a calcium signal inside the cytoplasm of the cell, they would actually be able to contract down and generate some force. They're already in a state where they just can't contract any further, basically, even if the interaction between the myosin and actin filaments is activated. And when you then stretch them out by forcing more blood into the chambers of the heart and stretching the wall of the heart out, then they're now going to have these sarcomeres in a position where if the calcium signal rises, they can actually undergo contraction and generate force. Okay, so there's a brief explanation of why the Frank-Starling law holds true. So basically, how hard the heart works is determined by how much blood is forced into the heart during diastole. If we lower central venous pressure, then the amount of blood that's going to be forced into the heart during diastole is going to be lower, and there's a fancy word for this. The end diastolic volume is going to go down, or rather a fancy term. So the EDV means the end diastolic volume, and this is just a fancy term for how much blood is in the heart, is being pushed into the heart by the end of diastole. Okay, so if the central venous pressure goes down, the end diastolic volume goes down, so the volume of blood that the heart will have to be contracting on will have reduced, and therefore you won't have as many of the cardiomyocytes stretched. So when they do contract, fewer of their sarcomeres will actually be activated, therefore their ATP consumption will go down. So this reduces the amount of ATP that the cardiomyocytes are going to need, and therefore reduces oxygen demand of the cardiomyocytes. Now you might say, well, there's a problem here, because that's going to mean cardiac output is going to go down. If we're bringing less blood into the heart, and now the heart is contracting less hard, then that's surely going to mean that the stroke volume is going to go down. And I would say, yes, you're completely right, but look, we've also brought down mean arterial blood pressure, and that hopefully will help to compensate for the fall in the end diastolic volume, because if we bring down arterial blood pressure, then of course more of the blood in the heart is going to be able to be pushed out into the arterial system, because the blood pressure is what's resisting blood going into the arterial system. So if blood pressure is now lower, then we're going to have an easier time forcing blood out of the heart and into the arterial system. So that means that the ejection fraction, the actual fraction of the blood that's in the heart that is ejected into the arterial system, is going to go up. Okay, and that will help to compensate for the drop in the end diastolic volume, and hopefully will help to maintain cardiac output. So overall, what you just need to understand here is that, to summarise this, the heart's job is to take bucket loads of blood from the venous side and push it into the arterial side. If we have now lowered both of these pressures, then you can imagine that the actual amount of energy that the heart is going to have to expend in taking blood from here, taking a bucket load of blood from here, and pushing it into there is going to be reduced. Okay, so overall the heart then is going to consume less ATP, and therefore its demand for oxygen is going to go down, and that's why even with this reduced blood flow due to the atherosclerotic plaque, if you are expending less energy in the cardiomyocytes, then you're going to not have so much of a problem with lactic acidosis. Okay, and that's why it produces relief from angina. Okay, so nitrovasodilators, they make the heart work less hard rather than increasing the blood supply to the myocardium. Okay, now let me just mention another one of these nitrovasodilators which is important. So another one that is used is isosorbide mononitrate. So isosorbide mononitrate. And this one's used more prophylactically than glyceryl trinitrate. So GTN, glyceryl trinitrate, it's very much so used as required medication. You take it when you're actually having an angina attack. Isosorbide mononitrate is used more prophylactically, so it can be taken orally, and it will be taken on a regular basis to try and prevent you having an angina attack. So to try and allow you to be able to do more exercise, to exert yourself more without actually having an angina attack. Okay, so isosorbide mononitrate, it would be taken orally on a regular basis, and the fancy word for this is we would take it prophylactically. So prophylactic or prophylaxis refers to taking a treatment in order to prevent something happening. So it's a treatment that would actually prevent angina attacks from occurring. Okay, so you take isosorbide prophylactically on a regular basis to try and prevent yourself from having an angina attack, and the mechanism by which it would work is the same. It reduces central venous pressure, reduces mean arterial pressure, and therefore means that the heart has an easier time, needs to expend less energy in moving bucket loads of blood from the venous system to the arterial system. So that means that the demand that the heart has for oxygen is going to be lower, and therefore even when you actually do begin exercising, hopefully then now the amount of blood that can come through your coronary artery with the atherosclerotic plaque in is going to be large enough that you're not going to actually get the ischemia occurring. Okay, right. So isosorbide mononitrate, another nitrovasodilator that is commonly used and will be taken prophylactically. And you can have both of these. So you can take isosorbide mononitrate on a regular basis prophylactically, and then if you do still suffer an angina attack, you can have your glyceryl trinitrate spray or tablets to take to relieve the attack then and there. Okay, so there's my first example then of an anti-anginal drug. I've got two more classes of anti-anginal drugs to talk about. Beta blockers, which are very commonly prescribed to reduce the likelihood that you'll actually suffer an angina attack, and also calcium channel blockers. But I think we'll have a break here, and in the next video we'll go on to those other anti-anginal drugs, and then we'll talk about the anticoagulative medications that we put people on to try and prevent thrombosis from occurring over ruptured atherosclerotic plaques.